She's Ms. Poonam. She's dedicated to data entry. You have to have a structure. Whether Dr. Bandari is around or not, she's doing her job entering the data. So the patients who got admitted yesterday, by the end of today, their data is entered. We have a PhD research person that works with us. That's Dr. Mohit Bandari, the program director, and I'm sitting there as the advisor. That data is entered prospectively, and you can do that at your institution. And we have a team that works with two of them. Then for the follow-up data, we have two dedicated nutritionists that follow the patients at 3 months, 6 months, 1 year. So in March, they are calling the patients who had surgery in December last year, December the year before, 3 months before, and they do that routinely. If they get the data from the patient, that's good. If they don't, we collect a certain amount of data. So you're going to get some patients that don't want to be disturbed, you're going to get some. But when you get a large amount of data, it tells you a story. Then we have the multidisciplinary team. You meet on a weekly basis. Data does you no good to collect it and keep it in the computer. We meet on a weekly basis and we go over our data. We go over what happens in the outpatient department. We look at what happens on the ward. The ward physician, bariatric physician gives a report. The marketing department gives a report. The nutritionist, the physiotherapist give a report. And then the doctors give a report. Then we discuss it. We look at our complications. I'll just give you an example. This is the team we hired. These are the electronic specialists, they're MAS. I'm not publicizing for them. I'm sure there are other companies that exist. But this is the one we use, MAS, and they give you this database. What they do is take the dendrite or whatever database you have and modify it to meet your particular needs and your particular population. And they charge you per patient. So we have a combination of our local team and the MAS team in terms of putting this structured data together. And last week, for instance, we just had a meeting on Thursday, which we have every Thursday at 3 o'clock, and we talk about our database. I'll just give you the surgical database. We looked at the total number of surgeries done that week. We did 52 surgeries. We do routine intraoperative endoscopies. All that are notified. You can see out of the 52 surgeries, we did 50 which were bariatric. Of those, 48 had intraoperative endoscopies. And if we found any abnormalities, that's entered into another set of data which is presented by 108, and then two were non-bariatric. Then you go to each type of surgery, you can look and see what type of surgery was done. This is what we did the week before, and that data was presented last Thursday. You go to the gastric bypass, you look at it the same thing. You go into the MGB, you look at it at the same. So you keep this data prospectively. And this data is kept, whether Dr. Fobi is around or whether Dr. Bandari is around. There are people who put this data in and it collects. After a while, you have a lot of information you can talk about. You can look at the complications. You look at whether you put in any balloons or not. Or you look whether you had any other surgeries. And we do occasionally do other surgeries, like I did a sleeve gastrectomy with DJB, loop duodenojejunal bypass, and that is entered into the database. So by the end of 6 months, you have a lot of data which you can keep and look at. You look at whether you did any other non-surgical bariatric procedure, tummy tuck, abdominoplasty, hysterectomy, and that data is kept. And then you look at whether there was any problem. We had one case we could not do because when we went in, the belly was completely a cement. We could not enter it with a scope with any form or shape. So we postponed it, and I think we later on did an endoscopic sleeve gastroplasty. When you keep that data, you collect a lot of information. This is what we keep. This is what is a structured database. It's electronic. It's not like the old days where we used to write things on papers. When we started the registry, we used to put a lot of stuff on paper. Right now, this data is there on a daily basis. You can look at the gastric bypass and you can analyze it. You can look at the follow-up. You can look at the follow-up at 1 year, 2 years, 3 years, and then automatically it calculates your excess body weight, your total body weight, and your BMI and the changes. And you can take any particular patient and follow and see how the patient progresses. That is a structured database. It would help you make an idea. You can go in, like I did last week, to look at patients who had an MGB and a banded sleeve gastrectomy. This is about almost 1,700 patients in the MGB group and only about 200 in the banded sleeve because they didn't do too many. This is what I found. Resolution of comorbidities. MGB is about 86% in our institution compared to 77% with the banded sleeve. Then when you go to dyslipidemia, you see the difference. This is data that's available to us, so we know it. You can have that same data about your own center. We looked at nutrient deficiencies. We just pushed the button and I came out and said hemoglobin less than 12.5. In the MGB, 36. That is 90%. Down here is 22. So you do have deficiencies with the sleeve. Some people don't think you have a deficiency with the sleeve. You do have deficiencies. But if you don't look, you don't see. So you come up and stand here and give a lecture, well, we want to do the sleeve because it has no deficiencies. Well, did you look at it? No. So what are you talking about? You're giving us opinions, opinions, opinions. But when you look at the sleeve does produce deficiencies, and this is the deficiency you can see here, up to 46% of them in some cases. You even have up to 54% with total protein less than 6.5. And these are deficiencies we have. Okay? Then last, the quality of life. We looked at it and we're going to discuss that, and let me just run through the last few slides. But before you put in standard data, you have to standardize the procedures you do. Everybody at an institution knows what you mean when you do a sleeve. They know what you mean when you do an MGB. They know what length you're using. They know what you do when you say you're doing a banded gastric bypass, how long the pouch is, where the ring is, the size, the length of the length. Those are standardized. And then we have an algorithm. And when a patient walks in, you can walk into any of my technicians, my fellows, and say, what should this patient have? You can't be sitting there as a surgeon and have a patient come in and say, I want to have a sleeve. It sounds like you're a salesman. You can go and work out of Kmart. Yeah. But if you are a surgeon, the patient should come to you with a medical problem, and you should give the patient an opinion. Okay? You should be able to say, Dr. Prasad, yes, you came in with a BMI of this is what your weight is, this is your problem, and this is what I recommend. I find it very disgraceful to listen to a surgeon say, well, the patient walks in and says, I want a sleeve, so I'm going to do a sleeve. Then you might as well be a salesman. You might as well stand by the shop and sell different brands of hamburger. I want a cheeseburger with cheese and bacon. I want a hamburger with corn. We are surgeons. We cannot say we are surgeons, but we want to practice like salespeople. Okay? So you follow this algorithm. And once you do this, you're going to come out with a better treatment for your patients. I had some case examples here like this, a 57-year-old. The best procedure is a gastric bypass. Why? Because the patient has GERD and is a vegetarian. Okay? You can read the rest. Patient comes in, 28-year-old female, dysfunctional uterine bleeding. She has a sleeve because the bypass MGB causes anemia and other problems, and you don't want this lady to have it. You have a patient here who is 37 years old, very healthy, is a non-veg, referred by a doctor in your institution, is going to come back for follow-up, can afford medications. So you have to give that patient an MGB because that patient will be able to follow the instructions. Don't give an MGB to a patient who might not be able to take all the nutrients you recommend. So that is what a database helps you to do. We do other surgeries, and we do different type of approaches like they talked about here. And finally, that is our best thing, giving the patient the best operation based on a protocol that we have. Thank you very much. I'll take a few questions so I don't...
Thank you, sir, for the nice talk. I think we are already over with the time.
Yeah, 5 minutes.
Because all the candidates have to write an exam at 6 o'clock. So we'll have to...
Sir, one question.
I knew somebody was going to break in.
Dr. Phoebe, thank you very much.
Yeah.
Excellent presentation. You know about the necessity of database and registry. My only reservation is that internationally there is no algorithm on procedure selection. So putting this algorithm, which is a Mohawk's algorithm, it's not a evidence-based international algorithm. Yeah. In people's mind that you can do a procedure because patient is vegetarian, or you can do this procedure because of various factors that have. It's little difficult for. It should not be done for the students because this is probably not based on international evidence.
We're not talking about international evidence. We're talking about Indian experience. I'm talking from a center with 10,000 cases in 7 years, and I'm looking at the data. I'm one of the founders of the Bariatric Society. We looked at the data, we said things, and what I want you to do is correct me. Somebody gave a speech yesterday which was important. Whatever you do today in 5 years will be obsolete. If I don't start by setting up a standard, you're not going to correct it. So I've used the data we have to make these standards. And I'm putting it up for challenge, and I'm putting up for you to look at it and change it. So you are one of the naysayers, since there's not, who is going to make the international data if you don't make it? No, that's the question I ask you.
I'm not denying that.
Yeah.
But this is a training program.
Yes?
The impression should not go that there is a way to match a procedure to a patient.
Yes, there is a way. I'm sorry. If you don't know that, it's because you're not well read.
Internationally, sir?
There's a way, yes. When you go to international meetings, you're going to find them tell you exactly this is what you do. I gave you the abstract from the readings I did yesterday. For instance, if you're treating type 2 diabetes, we tell you what procedure is the best, which one is better, and the next, and the next, and the next. Okay? That's how the algorithm goes. You saw they put an algorithm there for treating diabetes. That was at the diabetic summit meeting in London last year. So I don't know if you don't attend these meetings and you're not conversant with it. Don't stand and say there isn't. The algorithm is based on other people that have published on other places.
I completely agree.
Yeah.
You have been my teacher. But a particular center's algorithm cannot be applied universally in the students. You know, because worldwide I believe there is no algorithm to identify a procedure with a patient.
Let me explain to you. I don't think you know what an algorithm is. An algorithm is a guide. It's not a law. Okay? It's a guide. It means you come here, and if this patient has a problem, you go this way. That is the better of 3 ways. There might be 3 ways to go. This is the best, and then there are 2 or 3 other ways. Then you go this way, there's 3 guides. It does not mean that it's a law. I'm not telling you you have to do this. You can still do GERD, a patient with sleeve, give the person who has a GERD, you can still give him a sleeve. But you know that a gastric bypass is better. That's what an algorithm does. Tells you what is better. It doesn't tell you what you have to do.
We would have to move to the next talk, sir.
Thank you very much.
One question.
Dr. Abhay, your time will be taken away.
That's okay. I'll sacrifice 30 seconds of my time.
We start with your time now.
So, sir, you come from a high volume center and with patients from all around the country and world, and with a program like this, what is your follow-up rate at 1 year, 3 year, and 5 year?
We have that data. I can give you a presentation. I won't be able to give it to you today. But if you looked at any of the data we published, we gave you a follow-up rate, which ranges from anywhere from 40 to 74%, depending on what patients. That's why we have somebody doing the follow-up. But yes, we do have that data, and I don't want to take up too much of his time. Thank you.
Thank you, Dr. Pobi. And I would like to invite Dr. Agarwal from Mumbai. He doesn't require any kind of introduction. He's a renowned bariatric surgeon. And he is going to talk regarding role of support group activity in optimizing bariatric program. Dr. Agarwal.
I would request the audiovisual guys to ring the bell at 15 minutes and the speaker will restrict their time of speaking to 15 minutes so that people can actually deliberate.
I'll finish earlier than that. I have only 10 slides.
Yeah.
Good afternoon, everybody, and thank you, Dr. Narvaria, for the opportunity and the invite. And well, for the last 1.5 days, all these aspiring and budding bariatric surgeons and fellows here been learning how to become a fantastic bariatric surgeon. You're going to go and do procedures with probably no complications. You've learned the nitty-gritty of the fine aspects of the surgery. What if you collect 50 patients, 100 patients, you've done a few hundred patients, how do you follow them up? That is going to be a big challenge later on. So my topic today is role of support group in bariatric program, and I bring you greetings from Mumbai. So the support group meetings, I term them as the after-sales service in bariatrics. Once you collect a sizable number of patients, and how do you manage these patients is going to be a challenge. In spite of your dietitians, in spite of your recalls, most of the high volume centers and the most effective centers have lost patients for follow-up and can clock only 60 to 70% follow-up, as Dr. Malfobi just said that his follow-up rate is between 40 to 70%. So support groups are your building blocks, and they not only help you follow up your patients, but can also help you convert your new patients into your potential surgical patients. Studies have shown that regular attendance at support groups by these patients actually has better short-term and long-term results. Why are they so important? Because it's a multifactorial program. Just surgery or doing a good surgery or just giving good supplements is not enough. There is a lot that the patient has to cope up with. There are multiple aspects he has to change in his life. So foremost and important is the education. When you stand on a support group, you are at a common platform where you have the ones who have done the surgery, who are ahead of you, and who can guide you. And you can also follow them up because you know that you are not the only ones fighting this battle alone. There are others who have gone through it and are successful. Some of the old players, they get back to their old habits, wrong doings, and they experience weight gain. So these support groups often help them to get them on track back. There are some long-term players who have been older patients, 1 year, 5 years. They don't only themselves get motivated by attending these programs, but they can help the newer ones. And when it comes from a patient who has been in their shoes, they take it in a better form. Even though your family and friends have been very supportive, but it's not the same when it comes from a patient or a fellow patient who shares a lot in common. They usually feel safe to vent out their feelings, their thoughts, their fears, and friends and family outside of this platform may not be able to understand what these patients are going through. There is a lot of effectiveness to these meetings because regular attendants are known to lose more weight and cope up better with the surgery than who don't attend these meetings. We have done so many different changes to their anatomy. We have so many do's and don'ts for them. Eat 6 meals a day, eat with a small spoon, chew 20 times, don't have liquids with your solids. I mean, this is overwhelming for the patient. It cannot be digested because these habits have been there. They've been doing this for last decades, few decades together. And to change these habits are not easy. And there are serious consequences if these patients don't follow these instructions, correct? So support groups usually help them adjust emotionally. I have patients who have had post-op surgical depression, so to say. They get depressed because initially their plate size was this, and suddenly they are asked to eat only this much. So this emotional support of post-bariatric crisis is met with when they attend support groups, and these patients help them cope up with these problems. It's a new journey, and they can share a lot of common experiences when they attend these meetings. You can make these meetings more interesting by inviting food and fitness experts or enthusiasts. I know some surgeon in Kolkata had organized a ramp walk for their patients. So if you make these meetings more interesting, it is attended by many more patients. Members can be from different stages in their weight loss journey. Speaking to them who are months or years ahead in their program is not only motivating and educating, but these patients can get a glimpse into their future life. So once they see that others have gone through the difficulties and have now emerged more better, thinner, lost all their comorbidities, are diabetes free, it gives them a motivation. It helps maintain motivation to learn and overcome difficulties and outcomes from their program. Some people may be facing some difficulties, and when they get those small little tricks and tips from older patients, it works in their benefit. So as they said, together we succeed and united we stand. So support groups will be your building blocks. New patients who attend the support group meetings, it will be much easier for you to convert them into surgical patients otherwise also. That's it. Thank you.
Thank you, Dr. Agarwal. Now, one straightforward question to you and the audience also. Because see, this is the very important thing for those who have already started bariatrics. They are doing good number of cases, but they are not able to increase their number. So, I would like to ask Dr. Agarwal, what are the specific tricks or you can say the ideas regarding newer kind of support group meetings which can attract more and more patients to at least attend that support group meeting, because that is the thing which can become a very much good practical tip for rest of the people in increasing their number of cases.
So in my personal experience, I would say you have to make support groups more attractive, more attainable. They don't have to be boring meetings where just the dietitian comes and gives you a talk. The patients themselves eventually start organizing their own support group because they have made new friends. They come up with better ideas, like a fashion show or a yoga class or a Zumba class together. And if you are operating at multiple cities, you can choose one of the leaders and you can create a small support group in that particular city, because I operate in 4 different cities. So it gets difficult to have patients follow up in Bombay. So they can have their own little support groups and they work very well.
One tip from our side is that when we decided to involve some senior plastic surgeon also, so that those patients who are operated and those who require corrective surgeries, they can have some idea.
Absolutely.
That is also one tip.
You have to make it interesting. You have to make it...
Dr. Phobi, your tip. And then Dr. Khetan also, because he is also having a good follow-up and support group meeting at his place.
Thank you very much. That's an excellent presentation. I want you to know that the person who started the idea of support group is talking to you right now. In 1978, in private practice, I started the support theory. And the academicians at that time questioned it like I was questioned earlier today, because I was using patient counselors to run the support group. But to answer your first question, one of the best tricks is for the surgeon to make an effort to attend as many of the support groups as he can. When you talk to your patients, the day your patient has surgery is her new birthday. When a fat person, 130 kg, comes down to 90 kg, they have a new life. They start counting their life from the day you did surgery for them, and they look up to you, the surgeon. And if you can travel from Mumbai to Ahmedabad to a support group and your patients see you, they know you're concerned. They will refer other patients. They will bring other patients to the support group. And that is how I grew my practice. And those of you, I speak clearly because I'm here to teach. Those of you who know my boss, Dr. Mohit Bandari, he never went anywhere. Now, in the last 6 months, Dr. Bandari is out at support groups all over the country. And he's finding out that when the patients hear Mohit is coming in town, they are all there, even here in Ahmedabad. And that is why we're doing so many cases. And that can apply to you too. You go and see your patients, they know you care. And then you will see for real what you're talking about. The patients will tell you, I'm having so many loose bowel movements, I can't do anything. If you all the way across town, you never hear that. But when you come to the support group, the patients will tell you those things. So to answer your question, yes, support groups are good. Try to attend the meetings yourself.
Yeah, I think there is one more. Yes, please.
Yes, Dr. Lewis.
In fact, wherever I go, I always insist that I should have support group in different cities, whether it is Delhi, Bombay, Calcutta, Hyderabad, or anywhere. So I think it works. What Bobby said is very right. I think support group is the most important part. They feel connected to you, and they always try to bring more and more patients.
Yeah, more and more, I think in this era of technology, we can use Facebook, social media, as well as internet presence to talk to our patients, to run virtual support groups, to actually do a Facebook Live with your patients in a closed Facebook group. And you can stay connected without them physically, because the major problem for most of the patients is to travel to the support group and the doctors also. So if some people are finding difficult to hold a physical support group, that can be a more frequent activity.
Just as a human weakness, what are the chances of the patients picking up the weaknesses or the problems of the other patients in support groups?
Yes, that is a possibility, but most of these patients, once they have lost a certain amount of weight, they have lost their comorbidities, they are in a euphoria. Most of our patients, you see, one happy patient always brings you at least 2 more patients.
In fact, we should not be worried about it, because see, everybody should speak good or bad in support group. So I think if somebody speaks bad about the procedure,
No, those who genuinely had problems, those who, not the complications,
then
but the problem.
that is where the surgeon's role is very important, because we can address those issues there only. Why the problems are and how we
Because
can
they see 100 other patients who are happy and satisfied and only one is unhappy, that means there is something wrong with that.
I think that is a concern which we have, but it doesn't happen really. So we make WhatsApp group of our patients, and we think that, you know, on WhatsApp it's very easy for one patient to write that this didn't go well, but nobody does that actually. Most of the patients are happy.
Yes, Dr. Khetan, you would like?
Not much to say. How I conduct my support group is very different. I go into the clothes of my patient. If you get a surgery at 150, what problems you are going to have after that? A patient who has not walked for years together, we ask them to walk, they'll start having pain. So let us address their pain. They'll start having loose skins, let us address that. Loose bowels, let us address that. Address their problems, then only they will attend, otherwise they will not attend. Second thing is that, rightly pointed by Dr. Purohit, we had this problem. New patients, they will pick one wrong thing. No. I will not be able to eat, so let me reconsider my decision. Really, let them reconsider their decisions. It is good that they are not getting it done now. Let them understand the surgery and then get it done. Losing one patient here and there just because of support group doesn't mean you should not do it. You should do it. And just go into become a patient yourself, think like a patient yourselves. You will be knowing what their problem is because you are counseling them day in and day out after surgery. And just try to address their problems by an expert and you being present there. That takes away the problem. In our support group, almost there is an attendance of 200 now. The reason is that only, they come, they know that something is going to come out of the box which is going to help us, just not a mere lecture.
Thank you very much. Now I will request Dr. Navaria sir, the diamond in the crown of the whole CME, to come and speak on obesity in childhood and adolescence.
Thank you, chairpersons. Thank you for all the delegates and faculties who could stay. Though I know it is very, very hectic program, I'll try to quickly run through this. Just on lighter side, just to make a little laugh. If obesity is there in animals, just imagine what is the situation. And it is similar condition even with human beings also. If you look at the small kids, how they are surviving, how they are moving, and how they are living their daily life. So it's not that there is not a much problem of childhood obesity, but these smaller kids or syndromic kids are not being addressed much. In morning only, I think Dr. Fobi spoke about Prader-Willi. I think I may be having highest number of Prader-Willi syndromes, which I treated almost last in 15 years. So we do get such kids which need to be taken care, otherwise they cannot lead a normal life. So obesity is the most serious public health problem in this century. Globally, in 2016, the number of overweight children under age of 5 is estimated to be over 41 million. This is WHO estimate, and this is the chart which we usually use. We do get the newer machine, the body mass, body composition analysis by InBody. They even have a body analysis according to the age group. So up to 18 years, they have different body composition analysis, and they give even the growth chart in their chart. So we use this. So anybody who is more than 99 percentile, we usually offer them. So there is a study published in Pediatric Journal there is a longer analysis of children with BMI more than 99th percentile indicates that 100% of these kids remain extremely obese with an average adult BMI of 43 kg per meter square. And this is a vicious cycle, and these are the consequences which are there in childhood obesity. And there is an average life expectancy reduces by 2 to 5% in these smaller kids, and there is development of type 2 diabetes, hypertension, hypercholesteremia, atherosclerotic cardiovascular disease, and OSA and hypergonadism is a major problem in these. And there is increased morbidity, means increase in the healthcare cost for the society and for the nation. And these are the commonest serious problems which they can have. Even the smaller kids, they develop severe sleep apnea. Whatever kids I have operated, they had severe sleep apnea. We had kids with the type 2 diabetes, and we had even patients having pseudotumor cerebri with severe headache, and other complications like we had seen hypertension, dyslipidemia, steatohepatitis, and almost every disease which is there in those kids. In fact, we have a kid admitted in the hospital who has severe urinary incontinence because of weight with 65 BMI. So the prevention is the key in these patients, but it is really difficult, and that should be addressed when they are in growing age and should be taken care an early age of their life. Surgical options we talk about: Roux-en-Y gastric bypass, sleeve gastrectomy, and even people have tried adjustable gastric band. But most common in pediatric and adult age group is, which is being performed, is sleeve gastrectomy at the moment. But as Dr. Fobi said, the MGB and Roux-en-Y gastric bypass is also an alternative method which can be offered. This is again another article published in Pediatrics Journal in 2009, where they have talked about extremely severe obese diabetic adolescent having type 2 diabetes which is resolved after gastric bypass. And there is a complete reversal of type 2 diabetes and improvement in cardiovascular factors after surgical weight loss in adolescent. Sleeve gastrectomy, this is another article. The LSG has resulted in successful long short-term weight loss in more than 90% of pediatric patients, and 70% or more of comorbidities are resolved in subsequent 24 months of follow-up. This was a study of 108 patients ranging between 5 to 21 years, and this is from Saudi Arabia. I think this center has done good number of pediatric patients for bariatric surgery. This is another article from Chile, wherein sleeve gastrectomy was offered to 51 of these patients, and this is another article, the outcome of bariatric surgery in adolescent, wherein they have done 51 patients, wherein the mean age was 18 years, mean preoperative weight was 98 plus minus 13.3, mean preoperative BMI was 38.5 plus minus 3.7, and preoperative comorbidities were present in almost 76% of patients, which include insulin resistance, dyslipidemia, hepatic steatosis, and type 2 diabetes. And this is the result of excess weight loss, about 94.6% at 6 months, at 1 year it is 96.2%, at 2 years it is 92.9%, which is very, very good result in pediatric age group. And if you look at quality of life, it is good and very good, which comprises almost 100% in these patients. And of these, 76% with preoperative comorbidities all resolved or improved their condition after the surgery. And these are the criteria to offer bariatric surgery to adolescent where they failed 6 months of organized attempt of weight management, or nearly attain physiological maturity. There is severe obesity of BMI more than 40 with serious comorbidities, and those who are super obese with more than 50 BMI, even with lesser severe obese comorbidities, can be offered this surgery, and they should be capable or willing to follow nutrition guidelines, and they should be having significant family support environment to offer them. This is just a case study of these 3 kids which were very famous worldwide recently, called Sumo Kids. We operated 2 of them, and I already shown the video. The quality of life was very bad, and this was their preoperative status when the 6.3-year girl was having BMI of 57 with weight of 82 kg and height of 119 centimeter. And The other girl, Yogita, who was 8 years, has her BMI is 41, weight of 59, and both of them has lost close to. And this picture maybe 3 years back, but they had grown. They were treated in medical college. They were not being improved with it, but when they reached me, they were grown to a significant size, and we had risk of getting complications in these kids, so we treated them. We have done, this is the lowest BMI patient which is reported in world literature with 15 BMI. I have done BPD for hypercholesterolemia, and this was published. We have done BPD, and she never lost weight after bariatric surgery, but her xanthomas and hypercholesterolemia has disappeared, and this is our publication on this. This is a Prader-Willi syndrome. We have done almost 11 years back. And this is the severe leptin severe sleep apnea boy of 3 years who underwent surgery, and similar such patients. And look at this boy. If you look at this, those 3 kids were obese. This boy was having the bent leg. The legs are not straight. So I operated both the boys. This girl was operated at some other center, and tomorrow we are doing her revision because she underwent sleeve gastrectomy and she could not achieve the good results. She is still having BMI of more than 60. So we are offering her revision tomorrow in our workshop. And this girl was only 15 years with severe psychiatric discomfort, requiring ECTs to control her psychiatric problem, and she underwent this surgery, and we could avoid the ECTs on her, and we could even improve her condition. She is such a good singer. And this boy was having severe sleep apnea. He underwent this surgery almost 11 years back with 129 kg and BMI of more than 50. And we had a similar case of severe sleep apnea at 9 years of age who underwent this surgery long back, and few of such cases. I think with this I end my talk, and thank you very much. Just a caution, like this girl who can just see, you can see the legs. She was 115 years. If we don't treat her, since we delayed the treatment, you just look at her bones, they have bent already. How can she lead a normal life with so much weight? So we need to address, and there are no guidelines for childhood or pediatric age group worldwide. I think everybody offered only after 18 years, but these kids need a special treatment, but such cases to be handled at centers which are really having a good and high volume practice. Thank you very much, and I think we'll...
Thank you, sir, for giving time. 3 questions, please.
Very nice talk, sir. So, what about your data? As in, now you have done more than 50 patients? How many adolescents?
Yeah, it's more than 100.
More than 100. So
yeah, we are compiling the data.
Collective data, as in terms of the number of years of follow-up, and how have they done in nutritional and growth terms?
Yeah, the pediatric age group, there is a different challenge. Our nutrition are working very hard, very close to them. Few of these kids who are poor, we completely support them free of cost, including we are paying for their follow-up. They are coming on our course and taking all the medicines from our own center, and our staff is helping them to get the medicines to their own place also. So we need to work, we need to give them special vessels, utensils which are being used when they serve the food to them, because these kids want to have a full plate. So we need to have specially designed utensils which we provide them, and we ask family and we train them so that they can be fed only on those utensils and vessels.
So collective data from your center can guide a lot of us.
Yeah, we are working on it, we are analyzing, and maybe I think within the next few months we will have our publication ready.
What is your choice of procedure for these kids in general and Prader-Willi in particular?
Prader-Willi, I have done sleeve gastrectomy, but we have done gastric bypass also at less than 18 years of age. Because no, MGB.
Okay, so what is the choice of procedure now after this experience?
I think those who has attained height, I believe MGB is a better surgery. Significant height, not the really too smaller kid like 3 years and 4 years. We cannot offer and why I'm little speculative about it. Maybe for the follow-up and medicines also, that is another problem. The supplements they may not take for longer period. So I think less than 13 years I usually do sleeve gastrectomy, but those who are having good height and mature enough, this usually they look we always offer bypass.
And any cases you remember of any problems in nutrition which happened after?
So far, no.
Thank you, sir.
Thank you. Thank you.
Let us close the session and move to the next session. Are we going ahead with the tea break or are we following the tea break? Huh? Yeah. So the next chairperson would be Dr. Ashish Shah, Dr. Khaitan and Dr. Sanjay.
So, coming to the last section of the meeting, actually the pediatric surgery journey is not completed till the post-weight body contouring is done.
चलाने का अपने बेटा ये अग्री है
Dr. Anita Singh is going to speak on the post-weight loss body contouring. He is a plastic surgeon from Delhi, very good friend of mine.
लग गया पॉइंटर दे देंगे पॉइंटर Good afternoon, everybody. Thank you for the... Dr. Khaitan, you want to come here? Thank you so much. Respected chairpersons, my dear friends, it's a bad time to have a presentation like this. I'm going to give you a brief overview about what happens after you do the fantastic thing of losing patient's weight. The patient is born again. And he treats you as God. And we as plastic surgeons, when we tell them, okay, we're going to give a cut here and there and you're going to have a scar, they curse us. They say, usually want the bariatric surgeons to do the belt lipectomies. They trust them only. They don't trust us. They are so averse. They say, the bariatric surgeon gave us few cuts and he took off my weight like this. I'm born again. And here you are, you're telling me you're going to have scars here. So it's not acceptable. But some people do get bariatric, post-bariatric body contouring. And I would just briefly go over to what all can be done. The usual complaints are a hanging abdominal apron, arms, deflated hanging buttocks, thighs, face, upper body. This is typical. After a massive weight loss, somebody who loses a BMI maybe from 40 plus to about 30 or 32, 35, he has multiple problems. He has lost weight, but he still feels fat. I still look and feel fat as the term they use. It depends on a lot on what people wear. In our culture, people have started wearing trousers and shirts and all. So it reflects. Your pant size doesn't go down. Your abdominal apron has to be hidden under the trousers. So the things don't change. People are happy that they've lost weight. They become more healthy. So post-bariatric body contouring now comes to
a person who's absolutely healthy. He's no more diseased, he's no more sick. You need to be safe in doing whatever you want to do. You need to be, these are the commonly done procedures: belt lipectomy, brachioplasty, mastopexy. Otherwise, other things are thighs which need to be tightened, facelifts need to be done, and upper body lifts. Important thing, to be very brief because time is short, I guess. The very important thing is it has to be absolutely safe. A lot of these procedures, especially a circumferential procedure where the skin is taken off from all round, a lower body is lifted, or a belt lipectomy, whatever you think of it, these are massive procedures. It takes about 5 to 6 hours for one procedure, and it has to be safe. The patient is now healthy, so one needs to take care of all the complications, need to be safe. One needs to form a plan. It is a good idea to see as to why it happens. Our body, when the skin, when it gets deflated, it still remains attached in the center, in the sternal area, linea alba, along the iliac crest, but it hangs at the other places. So it just hangs like an apron. It hangs like a lampshade. So, nutshell, when we plan to do a body contouring surgery, we need to have certain things in mind. The weight loss should have stabilized. The person is still losing weight. It's kind of a moving target. It is not a good idea to operate on a patient who's still going down in weight. He should be stable enough for at least 3 to 6 months. He should have come, he or she, it's usually a she, come to within 10 to 15% of her expected weight loss, and preferably should be below 30 BMI. Well, you rarely get people who are below 30. They're usually above 30, but above 35 is absolutely a no-no. It's a very high complication rate. Sometimes one can combine procedures. Belt lipectomy or a lower body lift, or also called a circumferential procedure, it is a very major surgery. To combine a belt lipectomy with other things is not a good idea. One can minimum do a liposuction of the hips and thighs, which could be lifted later. It also helps during the surgery of lifting the lower body. The other things that can be combined are brachioplasty, upper body lift, breast procedures, thigh, face. Usually it is preferred that one should have a gap of 6 months. I'm referring to all this because your patients are going to ask you as to what, when, how. You need to have a brief idea. Looking at the lower trunk, which is the major, most patients want their abdominal apron or the lower truncal hanging skin or deformity to be corrected. All of us know there are two ways, one doing an abdominoplasty or doing a circumferential procedure. Abdominoplasty does not address a lot of things. It just takes care of the anterior part. I'll just show you some pictures. You can understand why just abdominoplasty will not take care of everything. If you take a close look at the picture, it leaves these side nubbins which don't look good to patients. They come and complain to you. It doesn't take care of the hanging skin at the back and at the buttocks. If you look at this picture, if you can appreciate the bulges here, the patients don't like it at the hands of a cosmetic surgeon. The gentleman, if you can see, he has a hanging skin completely on the sides. Well, speaking of belt lipectomy, it is a major surgery. It takes about 5 to 6 hours. It needs change of position on the table. One has to operate on the front and the back. Usually it is done first the front side, one lateral, then the next lateral. Belt lipectomy or lower body lift, they're not the same procedures. Belt and lower body are different. Belt is usually for females where you want a good waist. Lower body usually is for males where it lifts the lower body and the scar line is below the iliac crest, below the antisuperior iliac spine. Whereas for the belt lipectomy, it is usually above the antisuperior iliac spine. The usual hospital stay is about 3 days, 3 to 4 days. Epidural is used for pain relief. The patient is made to walk on the day of surgery, and venous thromboembolism and the prophylaxis for it is very prime. That is why the patient is made to walk. Typically, after about a week, the patient is put on pressure garments to take care of all the edema. and the patient usually gets back to work in about 4 to 6 weeks. One is happy when one sees a patient like this. One can get a very good result. I'll just run through some pictures about difference between belt lipectomy and lower body lift. This is what happens. In a belt lipectomy, the scar is above the antisuperior iliac spine. It gives a cinch at the waist and it gives a good definition of the waist, which is preferable for females. If you put in a female the scar line below that, it kind of tents the skin there, and you will follow up in these pictures as to what happens. If you look at the pictures here, the waist is not formed well. So a belt lipectomy is preferable here. Whereas in patients the belt lipectomy would not give a good buttock definition, which a lot of patients don't like because it gets deflated very much. With a lower body lift, sorry. With a belt lipectomy, the definition is good. Well, this picture shows how it differs. A belt lipectomy where it kind of gives an illusion that the buttocks are good formed. This is another example of a belt lipectomy. Some patients, though they haven't lost weight, they haven't attained the BMI, you need to do at least a peniculectomy. This gentleman could not pass urine without lifting the whole apron. Sometimes you have a hernia which needs to be operated. So these are exceptions. Otherwise, you don't touch these patients for any body contouring surgery. This is typically, most females get a belt lipectomy done, a brachioplasty and a mastopexy. Some few examples of belt lipectomy. It is preferred that the scar should be symmetrical on both sides. The patients don't like it after surgery. I'm showing you this picture because I dealt a belt lipectomy. The patient did not like the buttocks. I had to do a fat grafting. If you can appreciate now, the buttocks are flat. I had to do a fat grafting here, and now if you can see the pictures, they are different. She was happy with it. Post-operatively, epidural analgesia is a wonderful thing that happened. After it's been started in belt lipectomy, one needs to appreciate that our scar line goes just below the epidural analgesia, the L3 vertebra. It's just very close to it. So the anesthesiologists are not very comfortable. Second, post-operatively, we give low molecular weight heparin or some kind of prophylaxis. And again, the anesthesiologists are not happy having the epidural catheter there. So the anesthesiologist needs to be taken into confidence, has to be consulted that these need to be done. DVT and its problems are the prime and they need to be taken care of. Once again, belt lipectomy is a major procedure that needs to be told to the patient. I will not now speak about the smaller procedures, especially the arm lift or the brachioplasty, mastopexy and upper body lift. This is an arm lift. The important thing to appreciate here is you don't see a scar either from the front or the back, but there's a huge scar running right across here to here, complete. This is the excision marking. Same here. One tends to, in this lady, you can see the scar here slightly. Brachioplasty is a kind of a daycare or a one-day procedure. Usually quite safe, except that sometimes one becomes very ambitious and takes out a lot of skin and is not able to close. You need to put a full thickness graft then, and it's a bad thing. One can have nerve injuries sometimes if one is very careless. One can have lymphedemas, but less. Usually one does liposuction of the areas and it kind of preserves the lymphatics. Upper body lifts, this is what happens. The skin remains attached at the sternum. The skin remains attached at the sternum and everything hangs around it like a lampshade. This is typically an upper body lift for a male. It crosses the axilla. The weight gain and the weight loss are different in different people. It's genetically predisposed. The image on the picture on the left, she did not put up any weight in the thighs. Here, they put on weight, deflated very well. They didn't deflate very well. When they deflate, if you can appreciate, the excess is both horizontal as well as vertical. A lot of people they practice thigh lifts with just a groin incision. That will take care only of the vertical lift. It doesn't take care of the horizontal thing. A better thing to do is give a complete vertical cut. It gives a scar, but one can do a good job there. This is typically a thigh lift, vertical thigh plasty. One doesn't see a scar. One major complication of thigh lift is if one does a groin dissection or gives a incision along the groin, is permanent lymphedema. If you get it, it's bad, it's not curable. So it is generally avoided, any incision in the groin. One can have labial spreading if one is very enthusiastic in taking off a lot of skin. So one needs to be careful. Nutshell, body contouring surgery is bereft with complications. Those small ones, usually wound separation, wound healing problems, sometimes kind of dehiscence. Very rarely one gets deep vein thrombosis, pulmonary embolism. It is mentioned and it happens sometimes, but rarely. If good care is taken, the protocol is followed. You don't operate on very high BMIs, it's good. Take home message, weight should have stabilized, should be within 10 to 15% of the expected weight loss, and there should not be any fluctuation, preferably less than 30 BMI. Thank you very much.
Thank you, Dr. Amitabh. Any question? So my question to Dr. Amitabh. Amitabh, here.
Oh, hi, sir.
Say, if you look at the number of the bariatric surgery, what is your perception? Why the number of post bariatric?
Post bariatric after massive weight loss, world over it is said about only 1/3 come for body contouring, but in my experience, I think less than 5%. I don't know. What do you say?
Same thing. I think most of the people, they accept what they have, or at times they are not aware that this is possible.
Yes, they're not also aware, but they don't.
It's a question of awareness among them, because many of them they will
No, it's basically change in